Hello, how are you? You're right, Jordan, I'm going to introduce you. Jordan. Jordan is a consultant in paediatric emergency medicine in Cardiff in Wales, and he is the Welsh representative for PAERUCI, which is the Paediatric Emergency Research Network of the UK and Ireland. He is he's the research lead for his emergency department, and his research interest includes all things related to emergency care of ill and injured children. My goodness, you're going to be busy then for the rest of your career, with a particular interest in serious infections and sepsis. Jordan, I'm really looking forward to your talk. About the incorporating the FIDO study. We've had a real lively discussion on the back of the 2 respiratory talks this morning, particularly about serious bacterial illness in children and respiratory testing. So maybe you can shed some light on that a little bit more in your study. Jordan, if you go over by a couple of minutes, I'll put my little camera on and say hi. Otherwise, Jordan, the floor is yours. Thank you so much.
Thank you. No problem. Can you hear me okay?
Yes, okay? I can, and I can see your screen. Thank you.
Lovely. Perfect. Thank you. So yeah, as Shug mentioned, I'm a PEM consultant in Cardiff, and this work was undertaken with Tim Zamana and Tom Waterfield on behalf of the FIDO study group and in collaboration with PAERUCI. So this is respiratory viral testing and invasive bacterial infection in febrile infants up to 90 days of age presenting to emergency care. So this is where I work in Cardiff in the ED, and across all EDs across the country, along with GP surgeries, paediatric assessment units. As we just heard, seeing febrile children makes up a lot of our workload all day long, every day. Far too many febrile kids, and a lot of these are young children, tend to be younger rather than adolescents, and a fair number are infants. So when we say infant, we're talking about up to 12 months, and when we refer to young infant, we're talking about up to 3 months of age, up to 90 days, and fever as 38 degrees or more. So we see a lot of febrile infants and febrile young infants across the country. And why is this an important group? So this group is at high risk of invasive bacterial infection. So that's meningitis or bacteremia. And there's morbidity and mortality with that. But the younger the child, the higher the risk. So this young febrile infant group are far higher risk of serious complications and serious illness than the older child that we see regularly. As you just heard from Damien and Shruk, they're also a challenge to assess. So all febrile children are a challenge, but the younger the child, the more non-specific the symptoms that present are, and the more difficult it is to assess. I'm sure I heard from one of Damien's previous talks, one of his colleagues had the mantra that you should never trust a neonate, and it kind of extends out to young febrile infants in general. It's very difficult to assess clinically. And they're also an expensive group. So there's been work across Europe looking at febrile infants in different age cohorts, and this young febrile infant group are the most expensive. So in the current climate of the NHS, I'm thinking about value-based healthcare. That's another reason to look at this group particularly. So because I'm not sure of the background of the audience entirely, so just to paint a picture that historically, and when I was training, before I became a consultant, I was taught that every febrile infant up to 90 days of age, and even kind of going into 4 months of age, would have a full septic screen. The words screen being used lightly, but they would have IV access, cited, blood cultures sent, bloods for FBC, CRP, urine analysis and urine culture, plus or minus lumbar puncture. So this full septic screen, as it was called, was just the standard of care for any febrile infant that came to the ED or to the assessment unit. And then near enough all of those babies would be admitted to the ward, and stay for a kind of minimum of 48 hours as those cultures, blood, CSF, urine, were all analysed in the lab. But that avoids missing any bacteremia or meningitis, but we need to think about potential harm as well for everything we do as clinicians and healthcare professionals. And so that's not a risk-free approach. There is pain with all these invasive procedures, there's the risk of complication for any invasive procedure. So there is a risk of harm being admitted to hospital as well. And there's also the kind of social impact on families of having to come into hospital and be separated for a couple of days. So in recent years, there's been a move towards what's called tailored care, where we look to risk stratify and pick out a low risk group from this febrile young infant cohort. So there are a number of different international clinical practice guidelines that do this, that advocate a tailored approach to pick out this low risk group. A couple of common ones or well-known ones to kind of point out would be the Spanish step-by-step guideline, and the Americans have the American Academy of Paediatrics, the AAP guidelines, and also the PECAN guidance. So PECAN is the American version of PARUCI, the research network. So if we have a look at an example of the AAP guideline. So this is the American Academy of Pediatrics guideline for this age group. So we know that infants less than 29 days, so neonates are at very high risk of invasive bacterial infection. So the pathway is different for that group. But at 29 to 60 days of age, if an infant comes in with a fever of 38 degrees or more, in the US, this guideline supports if they look well, they haven't got any obvious source of infection, so they haven't got a clear cellulitis, they haven't got an obvious swollen joint for a septic arthritis or osteomyelitis, then they would have a urine taken for urinalysis, blood culture, and IMs. So IMs is inflammatory markers, so blood, so PCT, FBC, the blood test. If we follow this algorithm, so if you have those tests done and your inflammatory markers are not increased, so you've got normal bloods, then you go to the right of this flowchart, and if you have a normal urine, you go to the right again, and you then to the bottom right box, which says need not perform LP, need not administer antimicrobials, observe closely at home, so discharge, and follow up within 24 to 36 hours. So this is the way things are going in the States, and across the world, a number of countries have this risk stratifying approach. And in the UK, we do have guidelines that support this approach. So this is we're not going to go through it in detail, but just to give an example, this is the BSAC guidance. This is the British Society of Antimicrobial Chemotherapy guideline. And again, it does pick out a low risk group as well. But none of these guidelines have respiratory viruses or respiratory viral testing incorporated into them. So that's what we're looking at here, is thinking about how respiratory viruses can influence our decision making. I think Shrug might have referenced this paper as well. So there's a number of studies that report a lower risk of invasive bacterial infection, so bacteremia or meningitis, in infants or febrile infants with a positive respiratory virus. So this is Greenfield et al. From 2021. This is an American study, about 600 infants, retrospective, and they were looking for the viruses listed on the bottom of the screen there, of the slide. So if the febrile infants tested positive for one of those respiratory viruses, the risk of IBI, of invasive infection, was less than 2%. And if they tested negative, the rate was 7.7%. This is just one of many studies, but this is the general kind of theme and vibe from most of the studies there. But they do tend to be retrospective, not particularly large, and most of them are American. So if we're going to use respiratory viral testing to influence what we do in the ED or in the assessment unit, it needs to be a point of care test, because typically we will treat these babies and investigate them very quickly. So in my hospital in Cardiff, if a febrile infant less than 90 days comes in, they'll typically have all their investigations and their antibiotics given if needed within the kind of hour mark, or not far off it. So there's no point of sending, as previous speakers have mentioned, no point of sending samples to the lab. They're going to take 3-4 hours to come back, and that's not going to prevent us from performing unnecessary investigations. So we need to have a point of care test if we're going to intervene and change our management plan early on. So I'm going to present some of the data from FIDO. So FIDO was the Febrile Infant Diagnostic Assessment and Outcome Study, which is the largest prospective study of febrile young infants in the UK and Ireland. And this was a planned secondary analysis within FIDO. So we aim to describe the association of respiratory viral tests and the risk of invasive bacterial infection for febrile young infants presenting to emergency care. This was a planned secondary analysis of FIDO. So FIDO took place across the UK and Ireland in 35 emergency departments, one in Wales, I think one in Northern Ireland, one in Ireland, 2 in Scotland, and 30 in England. Back in 2022-23, it was a year-long study. And as you can imagine, the inclusion criteria was infant up to 90 days of age with fever of 38 degrees C or more. And that could be recorded in the ED, or it could be a history of fever. So in the preceding 24 hours, we know that a history of fever at home links up pretty well to having the risk of having fever in the department. Outcome measures were invasive bacterial infection, so bacteremia and meningitis defined as culture positive or molecular testing positive, so PCR. We only looked at 3 viruses for this planned analysis. So we looked at COVID, RSV, and flu. And this was based on previous Paediatric work that showed via a survey that these were the most readily available point of care tests. So again, thinking about how we're going to interpret this and put it into our processes, then it needs to be point of care. So we picked out these 3 viruses specifically. And then planned subgroup analyses were age, so those less than 29 days and those 29 days and older, because again, we know that that lower age group is higher risk. We looked at those with and without respiratory symptoms, and we looked at those that appeared globally well or unwell. So more than 2,000 infants were screened for FIDO, and over 1,800 were included. 426 didn't have any viral testing, so they were excluded from the secondary analysis. So this left us with almost 1,400 febrile infants, so 1,395 febrile infants that had testing for one of those 3 viruses or multiple of the 3. And 45 of those babies had invasive bacterial infection. So 45 had meningitis or bacteremia. So that's a rate of 3.2%, which is in keeping with the kind of previous literature. So if we have a look at these 45 infants that had IBI, so 1,056 infants tested negative for a respiratory virus, and 40 of the 45 cases of IBI were in that group, so that's 3.8%. And 339 infants tested positive for a respiratory virus, one of those 3, and 5 of those had IBI. So it's a 3.8% compared to 1.5%. So that was statistically significant, but we feel as authors, I think the most clinicians and most healthcare professionals and families would feel the same, that 1.5% is still a fairly high risk of something which could be quite devastating. So probably no kind of change to practice based on that. But what gets really interesting is when you look at those over 28 days. If you take out that high risk group, again, we know they're high risk, that neonatal age group, never trust a neonate, take them out of the picture. And if you test negative for a respiratory virus and you're between 29 days and 90 days, if you test negative, your rate of invasive bacterial infection is 3.2%. But if you test positive, it drops right down to 0.7%. So quite a significant difference. Looking at the subgroups, so with respiratory symptoms, we didn't find any difference. Without respiratory symptoms, again, whether you were viral positive or viral negative, didn't make any statistical difference. Looking at well-appearing babies on global assessment, there was no association, no difference between those, whether they were test positive or negative for respiratory viruses. But for unwell-appearing infants on global assessment, there was a difference. So if you looked unwell and you tested negative for a respiratory virus, it was 8.8% of those babies had invasive bacterial infection. If you tested positive, only 2.2% had an invasive bacterial infection. So what level of risk is acceptable? So 0.7% doesn't help us make a clinical choice in the ED or wherever else we're assessing these children. And this is touched upon in the American Academy of Paediatrics documents, that kind of risk is not a decision. So what is acceptable? And what is interesting with that 0.7% is that the step-by-step approach, I mentioned the Spanish approach, which I'll show you on the next slide. The step-by-step approach is widely adopted. When I worked in Sydney a few years back in Australia, this was used there. Step-by-step was how we did things. They were shocked coming as a European how I wasn't used to having this kind of risk stratification approach to my management of febrile infants. But if we have a look at step-by-step, I'm not sure if you'll be able to see it very well, so I'll just talk you through it. So we start with how the infant looks. So if they appear well, so they're not ill appearing, you moved it down on the algorithm. And then if they're not 21 days, or not less than or equal to 21 days, so that they're older than 21 days, you move down again. If they don't have a positive urine test, you move down. If they don't have an abnormal PCT, so if their bloods are okay, you move down. And if they don't have an abnormal CRP or absolute neutrophil count, then you move down to this low risk group. So after going through all these steps, the step-by-step process, this low risk group has a rate of invasive bacterial infection of 0.7%. So this is by chance the identical rate that we're getting from a single less invasive test with a respiratory viral test. So from this study, what are the take-home messages? Well, young febrile infants with a positive respiratory viral test for COVID, RSV, or flu are at lower risk of IBI. Infants more than 28 days of age that test positive for COVID, flu, or RSV may be suitable for management without IV antibiotics, LP, and even blood-based testing. Shrup kind of mentioned here hesitancy, so this is going to be a subjective thing and I guess a dynamic thing between clinicians and families. But further randomized trials are required to evaluate how the introduction of respiratory viral point-of-care testing can influence outcomes of value to parents and caregivers. Just to kind of give some high-level evidence, there's a paper by Roberto Velasco based in Spain, and his group had looked at COVID. So they did a systematic review and meta-analysis of almost 4,000 febrile young infants that had COVID. So there was no comparator group, it was just infants with COVID. We kind of know that IBI rates in this group ranged between anywhere from 1 to 5% anyway. But they found that if you look at that out of the neonatal age group, so if you look at the 29 to 60 days of age group, the rate of invasive bacterial infection was 0.11%. So pretty low, and that this is kind of the highest level of evidence we have on this topic at the moment. We are doing a systematic review and meta-analysis on these 3 viruses with Tom Waterfield's group, so RSV, flu and COVID, looking at studies that do have a comparator between test positive and test negative infants. If you want to learn a bit more about that, you can read the protocol there, and we're in the data kind of analysis stage now, so hopefully we'll have that released as soon as possible. And you mentioned we're going to need prospective studies. So in Wales currently, we have been lucky to get funding from Healthcare Research Wales to undertake a study called REFINE, respiratory viral testing in the management of febrile infants presenting to emergency care. So REFINE is going to look like this. So a febrile infant comes to the ED, they get screened, they get randomized to either standard care, or they have standard care plus point of care respiratory viral testing, which will hopefully be with the bioMérieux Spotfire test. There you go, Henry, on brand there. And then we will be doing research about prior consent methodology, and then qualitative and quantitative work. So this is a pilot across 2 Welsh sites, and hopefully will lead on to a larger multi-center trial, hopefully that we can put through Paruki if I'm lucky. If you want to read more of the paper I presented in detail, you can access that here through Archives of Disease in Childhood. Yeah, and that's me. So thank you. I'm happy to answer any questions in the Q&A section.
Amazing, thank you so much. I always find that the rates, evidence-based rates of invasive bacterial infections is always lower than I think they are in practice. So it's great to actually see that evidence there. Thank you, Jordan. Stay with us, please, until the end of the session, where we'll be taking questions and answers. So feel free to turn your camera off and stop sharing your screen. And I'm going to, perfectly on time. Thank you, Emma. Hi, Emma. Welcome.
Hello,
I'm going to introduce you. So just give me a minute. I'm going to introduce you. This is Dr. Emma Lim. She's a paediatric consultant at the Great Northern Children's Hospital in Newcastle. She's the paediatric sepsis lead for the trust and has written Royal College of Paediatrics and Child Health podcasts on sepsis. She's also the course director for the National RCPCH Sepsis course. She's heading the Northeast Regional Team piloting the new national system-wide paediatric observational tracking project, SPOT, and introduction of the National Paediatric Early Warning System. She is a phenomenal researcher with the Horizon EU Perform and Diamond studies, looking for new tests in fevers in children. She's very passionate about working alongside children and families and young people, and she believes that easy access to high quality information is the key to empowering families and collaborating with primary care. Emma, you're going to tell us all the answers of
Thank you very much. I feel exhausted listening to you, Shrik, but thank you for that, very kind. Can you hear me and can you see my slides?
Yes, yes, thank you. Please go ahead, thank you.
Thank you for inviting me. So my name's Emma Lim and I'm a paediatric infectious disease specialist. I am not a microbiologist. So I do want to say, although I'm talking about blood cultures and beyond blood cultures, this is blood culture 101. And I'm glad to hear that there are lots of microbiologists, so I'm hoping they'll answer any questions with me. Although this talk is entitled Blood Cultures, this is not really about tests. It's about choices. It's about investigator and antibiotic stewardship. And if you choose a test, what are the consequences for your patients? And it's really great to be here with all these PEM people and with Paruki. This is the problem we face every day in our EDs. We see all these febrile children with virus. Most of them have viruses. As we said, 10%, 5 to 10% have serious bacterial infections and only 1% have sepsis. So it's like trying to find Wally. So I don't know if you've seen this before. You need to find Wally in here, and that's like spotting sepsis. So we don't want to miss sepsis, but we need to balance that with not over-treating. And that's where blood cultures come in. So the driver for blood cultures is this really great algorithm that comes from the Surviving Sepsis campaign. But what we know is that sepsis can be caused by all sorts of things, not just bacteria, so viruses, fungi. So although it tells you the first thing you need to do is get access and take a blood culture, that's not always going to give you the answer. There's some great evidence behind this. This is one of my favorite studies. It was part of the New York sepsis mandate. And it shows that by delivering cultures, antibiotics, and fluids in an hour, that it halves children's mortality. But let's think about it, because it's not the blood culture that's saving lives. It's any test that could recognize sepsis or serious bacterial infection. And in fact, blood cultures don't perform well. So in the Euclid study of children with life-threatening infections, only 50% of children who were in the intensive care had causative organisms identified. But let's think about what it looks like in our emergency departments every day. So I've given you a case here. This is Grace. She's 3. She's just started nursery. And surprise, surprise, for the last 3 days, she's had a fever up to 39.4. She's a bit snotty, but there are no obvious focuses. She comes to your emergency department, and the first person she sees is probably one of your junior trainees, one of your residents. Now, often they might be a GP trainee. They might not have necessarily met children before. So while she doesn't look very sick, your trainee might be a bit nervous. They wanted to get some blood tests to confirm that this is just a viral infection. But while they're about it, they're nervous. They've popped a cannula in, they've taken some bloods, and they've just done a culture at the same time because they don't want to bleed her twice. And while they're waiting for that CRP, they've popped that culture bottle in their pocket, because if the CRP is low, they might throw it away. And if it isn't, they'll think about doing something different. So let's think what's happening to that culture bottle. So blood cultures, the basic technology behind them hasn't changed since the 1950s. You put blood in a broth and you incubate it and wait. And hopefully it grows something. And this is our gold standard test. So it will identify an organism, but it will also look at antibiotic susceptibilities. But there are problems with it. It's quite slow. You're not going to get an answer for 24 to 72 hours. And at that point, so when it becomes positive, you might do a gram stain and plate it out to get antibiotic sensitivities. So let's look at the time to positivity, first of all. This is the Swiss Paediatric Sepsis Study. Now, if you look at this graph here, in fact, 88% of children had cultures positive by 24 hours. And in fact, the only ones that didn't, this green line here, was the cons, the coagulase negative stats. So actually, if you have a low suspicion of infection, like in our case, then there's no real reason to wait more than 24 hours to see if you grow anything. You could actually consider stopping the antibiotics and sending them home. Because it's a low incidence setting, so about 1% sepsis, if you wait to 36 hours, you will only pick up 1 extra blood culture for every 2,000 that you've sent. Remember, this is completely different if it's a child that looks sick and is unwell. And those high incidents, if you're worried, then you do need to wait. So moving on, there are other reasons that blood cultures are not the perfect test, although they are the gold standard. First of all, if a child has been on antibiotics beforehand, you might not grow anything because they're bactericidal, they work well. But you can have early sepsis, but you might not grow anything if they've been on antibiotics. Secondly, think about fastidious or fussy organisms, so mycoplasma. We had a big outbreak of mycoplasma last year. You won't find anything on a blood culture with them. And Kingella, so thinking about bone and joint infections, again, that organism, it just doesn't like the drink that's in the broth, so you won't grow anything. So you need to be thinking about different tests, PCRs. But the most common reason that you don't grow anything is because there's nothing in the bottle. So low blood volume. Nigel Klein did this amazing study in Australia, and they weighed all the bottles, and they found that in routine clinical practice, a negative blood culture is almost inevitable because the huge proportion of blood cultures have inadequate volumes of blood. And actually, he did a whole load of education, and even after the education, half the blood cultures were inadequate. They didn't have enough volume, and 25% were in the wrong bottle. Now, this is the manufacturer's recommendations. So 13 kilos is about a 3-year-old. So imagine you're supposed to be taking 6 mils from everybody under 3 and 20 mils from everybody over 3. I can feel all the pediatricians cringing there. But I would say the minimum amount you need to put in a blood culture bottle is 1 mil per age of the child. So I've told you that there's lots of reasons you can have false negatives, but this isn't really important. This shows you low blood culture yields. So if you have a disease that has a low pathogen load, or if it's a localized infection, so you don't have many bugs in your bloodstream, you're unlikely to get a positive blood culture. That includes community-acquired pneumonia, UTI, cellulitis, pyelonephritis, skin and soft tissue infections, and some of the bone and joint infections, particularly Kingella. So right, isn't that more than half of all the things you're seeing? In fact, the only things you might get positive blood cultures are for neonatal sepsis, because small babies, small volumes of blood, lots of bugs, and line infections or endocarditis. So just be thinking, am I doing a test that's probably not going to grow anything? And it gets worse because we don't just have false negatives, we have false positives. So the huge majority of the things that we find in blood cultures are not pathogens, they're contaminants, they're just things growing on the skin. And it's not a surprise because it's really difficult taking blood from children. They're wriggling around, it's hard. Does it matter if we have contaminants in blood cultures? Yes, it does. So this study is a great study. They looked at 104 ED cases who had contaminants in their blood culture. They weren't sick, they just had contaminants in their blood culture, and 208 case matched who had nothing, no growth in their blood cultures. The ones with contaminated blood cultures all ended up being readmitted because you were worried. Had you missed something? They needed readmission, they needed more tests, they needed procedures, but they weren't sick. They just had dodgy blood cultures. And actually, that cost $4,660 per patient. So contaminants cost money, and it costs pain and time for the families. So going back to our original premise, if you're taking a blood culture, don't just do it just in case. I want you to just think, do you need it? Is the pre-test probability that your patient has a bacteremia really low? Because remember, you're only 2% of blood cultures ever going to grow pathogens. And most of those are in the very young children or those with complex medical needs and comorbidities. Think about if it's a poor pickup, so like community-acquired pneumonia or soft tissue infections, and just stop doing them if you don't really need them. Be targeted. So I guess that brings you to what else can you do that aren't blood cultures? Now, this really isn't my area, so microbiologists, be happy to take the questions on my behalf, because what we're looking for is a new gold standard, a rapid, accurate test to identify pathogens and direct our treatment. Remember our current practice, what we're doing at the moment. Don't forget about taking history. Histories are so important. So diarrhea, fevers in a young child, ask, do you have a reptile at home? Salmonella sepsis is a cause of that. Think about your pediatric early warning score. That is telling you, is the child sick or is the child well? Because if that's normal, then there's a really high likelihood you can just send them home at that time. Think about your examination. We've talked a lot about the great work through Paediatric and the point of care tests that are available to you. So respiratory screens, urine analysis, and bloods. And then we're going to think about what you send off to the lab. At the moment, there is no one good diagnostic test for sepsis. White cell counts, not helpful. CRP, bit better. Procalcitonin, a little bit better, but there's still room for improvement. And all these tests have problems with sensitivity, which means there is a worrying number of false negative tests. And I want you to think about the tests we do. For so many years, we've been doing pathogen detection. We want to follow all those bugs and find out which bugs they are. And that's fine, but then it doesn't tell you the difference between invasive disease and colonization. Bugs are just there because they're there. It's slow, you need multiple tests. So the other way you can go is thinking about host responses. So if you catch an infection, your immune system will react, and we can measure that, and that is quite specific. So going back to pathogen detections, we've talked about blood cultures, but what are the new advances? What's faster? What's more accurate? There are things coming, which is fantastic. You can culture directly from bottles with MALDI-TOF. We already use PCR, but rapid multiplex PCR panels are coming. And here's 2 panels in blood that can give you answers for a whole load of bacteria in 3 to 5 hours, and metagenomics, which I'll talk about in a minute. So lots of things around the corner. But the really important thing to think about is, what difference do these tests make to your practice? So this is a great study. This is looking at the impact of the BioFire panels. So that was one of the blood panels on antimicrobial treatment and mortality in pediatric gram-negative bloodstream infections. So in this hospital, they took some children with bloodstream infections, and to start with, they just used their normal cultures, and then they swapped to the panel. And the panel reduced the time to the appropriate antimicrobial therapy by 55 hours. That's like really impressive. And interestingly, in almost 80% of cases, they had to change treatment, because on this panel, they also have resistant gene detection. So 42% of the children needed their antibiotic switching. So that's really exciting. Metagenomics, this just totally blows my mind. This is a technique that's culture independent. What you do is you take a blood sample, all the nucleic acids in that sample are targeted and sequenced, and then you deplete all the human DNA and shotgun sequence what's left. And with bioinformatic analysis, you can look at what you've got. You can see here, these are actually adults with suspected bloodstream infections. So with normal cultures, you only got 13% of positive results. But with this, you could get 65%. And what's interesting is, obviously cultures can only tell you if you've got bacteria or fungus or both. But with metagenomic sequencing, you could see everything: bacteria, virus, fungus, and any combinations. So that's a huge amount of information. It's unbiased. It's really useful in sort of culture negative cases. So think about oncology children. That's really difficult. They've had antibiotics before. They may be having very unusual infections, but it is costly, it's slower, and a lot of it is still in research settings. So moving back to the host response to pathogens, what we'd really like is 2 kinds of scores. One that tells us what's the pathogen. Is it a virus? Is it bacteria? Is it TB? Is it fungus? But also something to tell us about severity. At the moment, all we've got is CRP and procalcitonin. And then in the severity stakes, we've got lactate and base excess, but they're very broad. They're not really helping you. So what new things around the corner? Let's think about it in terms of a case. So this is a child that I saw over the summer. He was a 4-year-old, and he'd got some pain in his knee. It had been going on for about a week. He was worse. He was limping. He had a low-grade fever, and his knee was red and swollen. He got admitted. He had some full blood counts, which was normal, and a normal neutrophil count, which is what we would expect. We said it's not a very good test at identifying serious infections. His CRP was 80, so that's raised. But is that infection, or is that inflammation? His blood culture didn't grow anything, but we've just said it's low yield in osteoarticular infections. So does that mean he didn't have an infection, or does that mean he's got an inflammation? We don't know. So we decided to image him. We did an ultrasound. Now, if he'd had an effusion, we could have put a needle in that. We could have got some joint effusion and done some PCR on that. Of course, he didn't have an effusion, so we wanted an MRI. Oh dear, but he won't lie still, and we can't have an MRI under GA for another week. So we have to keep on treating him with antibiotics in the meantime. And what happened was, this child had a couple of days of IV antibiotics. He got switched to oral. We had to actually give him the whole 6 weeks of oral antibiotics, because in the end, this was his first presentation of oligoarticular JIA, juvenile idiopathic arthritis. And we really need to treat that by injecting steroid into the joint, but we had to be sure there was no infection. So what we want are new tests that rule out infection as well as tests that rule in infection. And what kind of things are coming? These are all cytokine panels. So this first paper, which looked at interleukin 6, 17, and CSF1, that showed that you could have earlier identification of osteoarticular arthritis and infections, which is great. And you can see how much better it performs compared to neutrophil counts, CRP, procalcitonin. This one on the other side is really interesting. They used a combination of procalcitonin and something called pancreatic stone protein. And this paper by Q, they actually looked at 3 different groups: children with Lyme disease, children with JIA, so arthritis, and children with osteoarticular infections, and they could tell them apart. So as these kind of biomarkers come through, I think things will change, and that's what we're looking for. And it's not just proteomics. Actually, there are tests that use genomics. So this is part of the Perform and Diamonds group that I'm part of. And we developed 2 transcript host RNA signature that could differentiate bacteria from virus. But at the moment, you've got the green tests. They're really easy. We've all got them, but they're not helping you all that much. The tests in yellow here, they're the ones that are coming. So the neutrophils CD64, this is a cell surface marker. Actually, we're all taking full blood counts. We've got that blood sample, but you do need a bit of extra kit in the lab to look at the flow cytometry. So that's supposed to be quite good for neonates. The MEMED BV test, we're currently doing an implementation trial in our ED here and in Alder Hey. So that is something that may be available. And these others are all ones that are coming. They're still in trial. And I want you to always ask yourself, do all these tests make a difference? Because there's no point in having a new test unless it changes. This was a great study done by Enitan Carroll and her team in Alder Hey, and they looked at a procalcitonin guided algorithm to see if they could reduce the duration of IV antibiotics. But unfortunately, it showed absolutely no difference to usual care. But interestingly, it may have been because they didn't use it for long enough, so it wasn't something that was part of their standard care. But we need more research like this. And the reason we need it is because your goal is better antimicrobial stewardship. Antibiotics are a precious resource, and we need to use them carefully. So what I want you to think about is, your clinical acumen is paramount. You need to think, do I actually need this blood culture? Is there a high index of suspicion? Or should I not be doing it? Because if you're putting it in your pocket, you probably didn't need to do it in the first place. Think about other tests that can help you identify organisms and direct your treatment, because your aim is to be smart about your antibiotic use, be specific, try and de-escalate, try and stop antibiotics. We need pediatric research more than at any other time. So I'm a huge fan of Paediatric and everything they do. And I have a big ask. We really need to think about broad research, which includes implementation trials and therapy guided trials. So to sum it up, there is no silver bullet. There will be many complex tests, and it's your job to understand these complexities, to be able to think, is this a pathogen? Is this a bystander? AI will not be taking your job. And for me, this was a really hard thing to understand. I have been within the Perform and Diamonds team for like 10 years. I absolutely believed we'd have a test to tell between bacteria and virus. But when we got the test, we actually found that it was telling us this could be bacteria, viruses, fungus. It told us every single virus that was in the child. And it was our job to understand the challenge of that interpretation and its clinical correlation. So choose your investigations carefully. Think about investigation stewardship. Understand the strengths and limitations of all these new tests. It's your job to know about what's coming around the corner. So in the short term, we'll get loads more rapid molecular panels. In the midterm, host response point of care tests, which may change how you do things, and metagenomics in the long term. And remember to improve antimicrobial stewardship. That's your goal. That's the nirvana. So be guided by this clinical and laboratory data. I'd just like to say a huge thanks. There is absolutely not enough room on this slide for the number of people I have to thank, but broadly all my colleagues, including the office buddies at the Great North Children's Hospital, all the team at the Alder Hay Hospital who we work with, the Diamonds team, and my sepsis nurses.